Hello.
Hello. Hello, sir.
Yes. Got it. ഒരു മിനിറ്റ്.
ഇല്ലല്ലേ?
Good evening, sir. Good evening,
evening.
madam.
Good evening. ഡോക്ടർ അരവിന്ദ് ജോയിൻ ചെയ്തെന്ന് പറഞ്ഞു, പക്ഷെ കണ്ടില്ലല്ലോ.
ജോയിൻ ചെയ്തു മാഡം. ഗുഡ് ഈവനിങ് മാഡം. ഗുഡ് ഈവനിങ് സർ.
കുഞ്ഞുമൈദി ഇനി ബാക്ക്ഗ്രൗണ്ട് അങ്ങ് മാറ്റാമോ? ഒരു സുഖമില്ല, ഇനി ആളിനെ കാണാൻ ഒക്കില്ല.
അയ്യോ, അതെനിക്കറിയില്ല കേട്ടോ മാഡം. മാഡത്തിന്റെ ഡിസേബിൾ ചെയ്ത് വെക്കാം.
ശരി.
വെർച്വൽ ബാക്ക്ഗ്രൗണ്ടിൽ പോയിട്ട് എന്നുള്ളതിലേക്ക് സെലക്ട് ചെയ്താൽ മതി.
വെർച്വൽ ബാക്ക്ഗ്രൗണ്ട് എവിടെയാണ്?
ആ വീഡിയോന്റെ സൈഡിൽ ഒരു ആരോ ഉണ്ടാവും. വീഡിയോ എന്നുള്ളതിന്റെ സൈഡില്.
ഇല്ല മോനെ, കാണുന്നില്ല.
വീഡിയോയുടെ സൈഡിൽ ഒരു ആരോ മേലേക്ക് ഉണ്ട്.
ആ ആരോ ക്ലിക്ക് ചെയ്ത് കഴിഞ്ഞാൽ വെർച്വൽ ബാക്ക്ഗ്രൗണ്ട് കാണാം. സാർ കണ്ടില്ലേ?
അതില് വീഡിയോ സെറ്റിംഗ്സ് അഡ്ജസ്റ്റ് ബാക്ക്ഗ്രൗണ്ട് അല്ലേ?
അഡ്ജസ്റ്റ് ബാക്ക്ഗ്രൗണ്ട് എന്നുള്ളത് എടുത്താലും മതിയാവും. അതില് വെർച്വൽ ബാക്ക്ഗ്രൗണ്ട് കണ്ടാ?
നോക്കട്ടെ. കണ്ട്.
അതില് നന്നുള്ളത് ആക്കി കഴിഞ്ഞാൽ ഇത് പൊക്കോളൂ. യെസ്.
അപ്പൊ നമുക്ക് തുടങ്ങിയല്ലോ കുഞ്ഞുമൈദി.
തുടങ്ങിയിരിക്കും മാഡം. നല്ല എല്ലാരും വെയിറ്റ് ചെയ്യുന്നുണ്ട്. സ്റ്റാർട്ട് ചെയ്യട്ടെ?
സ്റ്റാർട്ട് ചെയ്യും.
Hi, good evening all. Welcome to the KFOG Safe Motherhood Committee webinar series, the first of its episode today, organized by the Safe Motherhood Committee under the leadership of Dr. Prasanna Kumari, the chairperson of Safe Motherhood Committee. And today we have a very important topic, that is surviving the sepsis. And we have the speakers, Dr. Prasanna Kumari and Dr. Arvind Raghu Kumar, who is the senior faculty in the Department of Infectious Diseases at Medical College, Thiruvananthapuram. And we have a very wonderful senior and leading light in the field of obstetrics and gynecology, Professor P.K. Shekharan sir, who will be chairing this session and will be giving his expert comments. So we welcome all the speakers and the chairperson to this wonderful webinar, and we welcome all the delegates. And on behalf of the committee, I welcome Dr. Sujitra Sudhir, the President KFOG, and Dr. Subhash Millia, the Secretary General of Kerala Federation, to this webinar meeting. With these few words, I request Dr. Sujitra Sudhir to address the gathering. Madam, please.
Good evening.
Madam.
Good evening to all. We are very happy that we are having this very significant seminar because we have found that the leading cause of maternal death is sepsis. At the last CRMD, which was conducted in a very nice manner, we could find that sepsis is becoming the leading cause. Before we used to think it was PPH, but now it is sepsis. So this webinar is very important. And we have Prasanna Kumari Madam, who is the leader of the Safe Motherhood Committee, who is chairing this particular session. And she's also writing a wonderful article about this. And also we are so happy that Shekharan sir has joined us. Shekharan sir, although he is far, he will always be there with us. So happy to have you, Shekharan sir, with us. And Kunjumuddin doctor always a pillar of support. And he is the organizer or the architect of all these KFOG webinars. And this is keeping us all on our toes. And we are always up to date with so many programs. And today we have a very good speaker, the person,
Aravind.
Dr. Aravind, who is in charge of the infectious diseases in Trivandrum Medical College. And we have Shekharan sir as the chairperson and Prasanna Madam as the leading light of this particular session. So happy to have you all. So we are looking forward to a very informative session. Thank you so much.
Yeah, thank you, ma'am, for that wonderful words of wisdom. And over to Dr. Subhash Malia, the Secretary General of Kerala Federation, for a few words.
Respected President Suchitra Madam, respected Chairperson of the Safemotherhood Committee, Professor Prasanna Kumari Madam, Professor K.K. Chekran Sir, Sajra Madam, and all the senior, Dr. Kulimani Sir, the General Convener, and of course, Dr. Arvind from the Infection Disease Sir. Thank you very much for spending your time, sir. I think ever since Prasanna Madam has taken over as the Chairperson of the State Motherhood Committee, I think we have been seeing a very strong and a very academic sessions which are being taken back to back. I think Madam did speak in the last CRMD meeting that she would be taking a session on sepsis, which is causing one of the most, the causes which can actually help us reduce the maternal mortality in a big way, a big modifiable factor. And Madam is on her path to make it, into a success. And I wish Madam the very best. And I would like to thank all the delegates who joined. I think to have such a number of people on the webinar, 130 members, is not a simple deal. I think hats off to Madam and the choice of the subject. And also, I would like to thank Dr. Kunjumaidin, who has taken a lot of pains in organizing this webinar in the last, I think, in about last 18 months or so. Thank you, sir. Thank you very much for all of it. I know you're traveling all the way from Calicut to Perindalamana currently in the rain. And I'm sincere because this is the third webinar that you have been assisted in the last 1 hour. Of course, Dr. Shekharan sir, and myself, we have a webinar, we have an offline meeting here in Calicut, and also, sir, is a different room now for this. I think, thank you, sir. Thank you very much for fulfilling both the places over here. Thank you, sir. Thank you very much. And again, I would like to thank each and every delegate for participating and wish that it would be a very big success to all of you.
Thank you, Dr. Subhash. And it is my proud privilege to introduce our dearest Shekharan sir, who is the pillar of strength for all the activities of Kerala Federation. And I'm so thankful to him for giving me the support during the past 1 year, during my presidential year. And sir was the past president of Kerala Federation during 2003 and vice president of OXI in 2010 and founder president of National Society of Study in Trophoblastic Diseases in India and chair 15th World Congress of Gestational Trophoblastic Diseases in 2009. And he is currently he was the secretary and treasurer of International Society for Study of Gestational Trophoblastic Diseases from 2013 to 17. Co-author FIGO guidelines on management of GTDO in 2015, 18, and 21. And he has 51 publications to his credit and with wonderful 400 plus citations. And with these few words, and sir is above all a wonderful human being, a lovable person, and leading light for all the juniors and inspiration to all of us. Over to you, sir, to continue with the academic session, introducing the two speakers as well. Over to you, sir.
Thank you, Dr. Kunjumaidin, Dr. Prasanna Kumari, the chairperson, Dr. Swijitra, president of KFOG, Dr. Subhash Malia, Secretary General, all the delegates and friends. Before I introduce the speakers today, as we all know, sepsis is taking a great impact on the maternal mortality. It means we are now facing not the hypertension or the PPH, but sepsis is coming up as a leading cause of maternal mortality in our part. And all over the world, it is about 10 to 11% of the maternal death are due to the sepsis in pregnancy and labor and postpartum. So this is very important to know. And today's subject is actually surviving sepsis, that movement which was started and declared in 2002 as the Barcelona Declaration, with the components of the management as a bundle and the developments afterwards and updating the fundamentals of the management, changes in the management from the bundle changes, and actually it is the fourth or fifth guideline that has come. So without my telling all those things, let us listen to the experts for the today's speech. First of all, it is my privilege to welcome Dr. Prasanna Kumari, the professor and head of the department of Trivandrum Medical College as well as at Calicut Medical College, a wonderful teacher. She was the president of the Kerala Federation and also is taking a very keen interest and carrying forward our mission of continuing with the activities of the KFOG, especially the maternal welfare, the maternal mortality and reduction of maternal mortality, which is our prime uh, focus as the federation, and we are thankful that she is taking over that important task of trying to reduce the maternal deaths in our state and further reducing especially the preventable deaths. So Dr. Prasanna Kumari is there, and of course I think they are going to have a sort of a discussion or continuous talk. So I will also invite Dr. Aravind Kumar, who is the head of the Department of Infectious Disease at Trivandrum Medical College. He is associated with many of the government programs of prevention of sepsis and antibiotic programs, prevention of antibiotic resistance, and also in the governing body of the many of the government agencies. I am sorry that I can't see the CV of Dr. Arvind. Can you please to introduce this thing? Can you please
I have
check
to
that?
share the screen then.
No, because personally I haven't. I have heard a lot about Dr. Arvind, but I'm sorry I can't tell all his credentials because he is a very very important person in the whole of state of Kerala, because he is as a sort of advisor to the government of Kerala as regard to antibiotic policy that we have to follow, and he is heading and part of many of the governing bodies of the government also, and also helping us tiding over such difficult situations. I think Dr. We will see the this thing.
Thank you, sir. This introduction is enough, sir.
Okay, welcome. Sorry, Aravind, I think
No issues, sir.
okay, so we are having such an important person, especially in the management of sepsis. Now the bundle has changed, and especially the starting the antibiotics and what antibiotic prospect and other things. We will hear from the real authority of such a treatment, and we are happy that to have you here, and hopefully we will all listen to you carefully, and also we will have carry home the best updated evidence-based management of sepsis. So thank you very much, Dr. Arvind, and I think you can start, Dr. Sunumari, and both of you can start whatever way. I don't know whether it is a discussion or presentation by each. Anyway, we are all eagerly waiting for the same.
Thank you, sir. Thank you, Dr. Sujitra Sudhir, Dr. Kunjumaidi, Dr. Subhash Malaya, Sharon, sir. Dr. Aravind, I will tell about Aravind. He is the convener of Kerala Antimicrobial Resistance Strategic Action Plan, and he is the convener of Kerala State Medical Board, and he is the convener of Kerala Vaccine Policy Committee. He is the focal point for IPC and AMS Kerala State. He is the nodal officer of Antibiotic Literate Kerala campaign, and he is the member of the National Technical Expert Group on Antimicrobial Stewardship, and the chairman of Technical Committee of Kerala One Health Action. So I also welcome Dr. Aravind.
Thank you, madam.
Shall I share my screen? Yeah. So that is about Sharon sir already introduced. That's about myself. That's about Aravind. we'll straight away go to sepsis. And this I have chosen because in the last 2 CRMDs, that means last 6 months, sepsis has been the leading cause of maternal death. Am I audible? Am I audible?
Yes, madam. You are audible, madam.
Audible. Is she seeing the screen?
Yeah. No, screen is not seen.
What about now?
No.
I don't know what to do. Screen is not seen.
No, make it half and then you will be able to share the screen.
I will try. This is how I enter in all the webinars. Now, today only I have a problem.
Doesn't matter. സ്ക്രീൻ റെഡ്യൂസ് ചെയ്തിട്ട് അത് കാണും, അപ്പം അതെടുത്തിട്ട് ഓപ്പൺ ചെയ്തിട്ട് പിന്നെ അതാക്കാം, ഫുൾ സ്ക്രീനാണ്.
അങ്ങനെ മിനിമൈസ് ചെയ്തിട്ടിരുന്ന സാർ എന്നും ചെയ്യുന്ന പോലെ.
Doesn't matter, it is raining, so we will all wait.
ഷെയർ സ്ക്രീൻ. ഷെയർ സ്ക്രീൻ.
മാഡം മീറ്റിംഗ് ഒന്ന് ലീവ് ചെയ്തിട്ട് റീജോയിൻ ചെയ്തിട്ട് നോക്കണോ? Does that help?
minimize ചെയ്യണം ഞാൻ എത്ര പ്രാവശ്യം പറയുന്നു. ഇതാണോ?
Only cookies.
I'll enter to another computer. Because from this I am not able to project.
Okay, settle. Should I talk on something about the maternal mortality while you are settling?
Last CRMD, 3 of the maternal death, 2 solely due to sepsis and another 2 sepsis was a contributing factor. And the last 6 months CRMD, maximum deaths were due to sepsis, not because sepsis has increased, but we could conquer more of hypertension and PPH, as Sharon sir said, and it is sepsis. And number of sepsis when you take every year, it is coming up to 7, like that. It is almost remaining the same. Now also it has not increased. The number of deaths due to sepsis has not increased, but compared to PPH and hypertension, it is more. So if you want to reduce the maternal mortality from some say 30 per 1 lakh, still further, we have to conquer all these. One is sepsis, and another is heart disease, and yet another is very unusual situations. And hence it is very important that all the obstetricians are aware of how to deal with all these rare situations, sepsis and heart disease, as well as other rare situations where maternal death occurs. So that is the importance of sepsis. Not because sepsis has increased. We have conquered hypertension and diabetes, hypertension and PPH, and now we have to conquer sepsis. When it comes to PPH, it is when patient bleeds, the obstetrician will be alert, and all the staff will be alert. Almost getting ready. Whereas in sepsis, it is silent,
Okay, good.
We are almost there.
Yeah, it is there. We can see.
Okay.
I think you are muted. I think you are muted, madam.
Madam, muted, madam.
Now it is. I think she is muted, I think. കേൾക്കണില്ല. Somebody who is sitting with her. Oh, we can't hear. She is talking, I think. Seven pizza. ഒരുമിച്ച് കഴിക്കണം. അത് ബാക്കി ഞാൻ പൊതിഞ്ഞുണ്ടാവാം. ബാക്കി ഞാൻ പാക്ക് ചെയ്തോളാം. മീറ്റിംഗ് ഉണ്ട് കുറച്ച് നേരത്തെ. കുറച്ച് കഴിഞ്ഞിട്ട് ചായ കുടിക്കും. 1 മണിക്കൂർ കഴിഞ്ഞ് 2 മണിക്കൂറുണ്ട്. ഹലോ, മ്യൂട്ടഡ് ആയിട്ടാണ്, മ്യൂട്ടായി പോയി. അത് അവിടുത്തെ ആരാണ്? അവിടുന്ന് നിങ്ങളുടെ കൂടെ ഇരിക്കുന്ന ആരോട് നോക്കാൻ പറയും. നിങ്ങൾ അവിടെ മ്യൂട്ടഡ് ആയിട്ട് കാണുന്നു, ഫാക്കൽറ്റി മ്യൂട്ടഡ് എന്ന് കാണുന്നു. അതാണ് ആ ലോവർ പാർട്ടിൽ നോക്കിയോ? അത് അയ്യോ, സാരമില്ല, ഡോണ്ട് വറി, അതൊന്നും സാരമില്ല. അത് ആരെങ്കിലും ഒന്ന് അൺമ്യൂട്ട് ചെയ്യണ്ട. അത് ചിലപ്പോൾ അവരുടെ കയ്യിലായിരുന്നു കൺട്രോൾ. എനിക്കിവിടെ മ്യൂട്ട് ചെയ്യാൻ പറ്റുന്നതാണ്, അൺമ്യൂട്ട് ചെയ്യാൻ പറ്റും. സോ യു ഷുഡ്. ഇല്ല, യു ആർ.
ഇപ്പോഴ് മാഡം അൺമ്യൂട്ടഡ് ആണ് സർ, കാരണം റെഡ് സൈൻ കാണുന്നില്ല.
ഫാക്കൽറ്റി എന്ന് പറഞ്ഞ ആരാണ് അത് ഇങ്ങനെ മ്യൂട്ട് ചെയ്തിരിക്കുന്നത്? ഫാക്കൽറ്റി എന്ന് കാണുന്നതാണോ മാഡം?
അതെ,
അത് മ്യൂട്ടഡ് ആണ്.
അത് അൺമ്യൂട്ടഡ് ആണ്.
Now it is unmuted, I think. Okay, carry on. ഇല്ലില്ല, I think you are okay now. Talk. I think you can talk. ഇപ്പൊ അൺമ്യൂട്ടഡ് ആണ്, യു ക്യാൻ ടോക്ക്. കേൾക്കുന്നില്ല, ഇപ്പം മ്യൂട്ടായി. Now unmute. Okay, yeah, now talk. ആ കമ്പ്യൂട്ടറിൽ ഒരു വോളിയം കൂട്ടി വെക്കാൻ പറ്റും. ഇപ്പൊ അൺമ്യൂട്ടഡ് ആണ്, യു ക്യാൻ ടോക്ക്. പ്ലീസ് ടോക്ക്, യു ക്യാൻ. Faculty screen. Okay, you can see. Can't see her nor here.
We can see her, sir, but although she's unmuted, somehow I could hear her talking to you on phone.
That was
that
was on the phone.
Yeah, but I don't know whether the audio. Or actually, maybe to
Audio,
help.
I think the computer
leave
audio
the
can
meeting.
be increased. Computer audio can be increased if you can. On the lower part there is a.
Yes, computer audio is high.
Now
Now we can hear you, ma'am.
Okay, please carry on.
But what about the screen?
Everything is okay.
Can you
Everything is
see?
okay.
Don't worry. Okay.
Oh,
Yes.
Screen on adjust ചെയ്താൽ മതി.
half an hour gone, is it?
It's okay. It's okay. Welcome.
So say, infection is different from sepsis, and in sepsis, the immune system response is extreme, and there will be organ dysfunction. And in septic shock, there will be BP fall, and it can affect all the systems of the body. So infection is an identified source of microbial insult, and sepsis is a life-threatening organ dysfunction caused by the dysregulated host response to infection. Sepsis sometimes may not be diagnosed. That's the problem. May not be properly managed and resulting in maternal death. Pregnant and recently pregnant women are particularly prone to rapid progression to sepsis and septic shock. Pregnancy is a greatly immunocompromised state. So whenever we see pregnant woman, we have to see her as an immunocompromised individual. Is a very important point. And the magnitude of the problem, as I already said in the last maternal mortality review meeting, sepsis was the leading cause in last 6 months. But in the review of maternal deaths in Kerala by KFOG during the last 4 years, sepsis was the sole cause of death in 3 to 7% of the maternal deaths. And the important thing is the signs and symptoms of sepsis are non-specific and often mimic multiple other diseases. That is one of the main causes by which death occurs because of sepsis. A third of patients initially diagnosed to have sepsis may turn out to be having other non-infectious conditions like, say, massive pulmonary embolism, and vice versa also. Massive other disease problems can be misdiagnosed as sepsis. And these conditions are mainly acute pulmonary embolism, acute MI, acute pancreatitis, adrenal crisis, thyrotoxicosis, and other crises like SLD, etc. So, coming to clinical features, fever or rigor and diarrhea and vomiting may indicate exotoxin production, early toxic shock. And I still remember one patient who was admitted with diarrhea and vomiting, and the next day she died. It was long back. We didn't know that it was sepsis, and she was not properly managed. And rash, maculopapular rash or purpura fulminans, and rash can occur in a streptococcal infection. And another incident where one patient who was admitted with premature rupture of membranes, she was there for a few days, and finally she expelled. And the same day she developed rashes, and she died on the second day after expulsion. Maybe streptococci, which entered the system after the abortion. So we should be familiar with these rashes, which may be a fulminant streptococcal infection. Abdominal and pelvic pain and tenderness. A patient, a pregnant woman coming with severe abdominal pain, fever. It could be cholecystitis. It could be appendicular abscess. It could be diverticular abscess. And if it is a puerperal infection, she can have open infective vaginal discharge, smelly, because of anaerobic infection, or serothragirus if it is a streptococcal infection. And respiratory tract is another one prone for infection. And we should always think about it when when a very obese woman delivers, or very obese woman diabetic, and we will go for cesarean also. She's at very high risk of respiratory infection. And urinary infection also is common in pregnancy. And I think every woman should be screened for pus in the urine in all the trimesters. And it should be a clean catch specimen. Otherwise, it will be falsely positive. So that these are the most common sites of infection, I already said. And whenever she has an indwelling device, it can even be meningitis or encephalitis. It can be biliary tract, appendicitis, already said. Biliary tract, because we had a patient who had very high fever following delivery, cesarean delivery, but we didn't find any reason for any site of infection. And she had CT, and we gave her piperacillin tazobactam, and she responded initially, but again she had temperature, very high temperature. And then she had CT, and the CT revealed it was cholangitis. So any infection can occur in the puerperium or during pregnancy. So when it comes to how you diagnose sepsis, that is the main dilemma. Several clinical variables and tools are used for sepsis screening as well as prognostication. And these are the systemic inflammatory response syndrome, which I will come to, sequential organ failure assessment, acute sequential organ failure assessment, and the modified early warning score. When it is SIRS, the SIRS term was first adopted in 1991 by ACCP. The American College really adopts all these definitions. And sepsis is broadly understood to exist when an infectious process triggers the systemic inflammatory response syndrome. So she can have fever, she can have tachycardia, or she can have polycythemia. But SIRS is positive into the following criteria. And nowadays, it is not taken to diagnose sepsis, but I think for screening, SIRS is SIRS is better than SOFA, because in SOFA you have to do the investigations, and in SIRS it's only clinical, and it is good for screening, may not be for diagnosis. For screening, I think it's still SIRS is good. I don't know what the opinion of Dr. Aravind is. SOFA score was first developed by the working group on sepsis-related problems with the European Society of Intensive Care Medicine. And that is the score where you have to do the investigations. The respiratory PaCO2 FiO2 ratio more than 400. It should be more than 400. When it is coming less and less, the score increases to 4. And platelets, thrombocytopenia, actually thrombocytopenia speaks sepsis. Whenever there is polycythemia, when the leukocyte count increases and the platelet count decreases, we have to think of sepsis. And liver function abnormality, bilirubin increase, liver enzymes increase, TVS hypotension, mean arterial pressure more than 70 is normal. And if it goes below 70, or she needs dopamine or norepinephrine as an inotropic support, or the brain, the Glasgow coma score decreases, the score increases to 4. And the kidney, serum creatinine, urine output, and that is why when we are on the lookout for sepsis, she should be on a hourly output Eurometer. It should not be a simple bag, it should be a Eurometer, so that every hour's output counts. Every hour output can be measured, so that you'll understand when she's going for oliguria. And SOPA score of 2 or more is hypoxemia, oliguria, creatinine rise, coagulation abnormalities. Recently, we had a bowel injury following an onco surgery, and her coagulation, she was looking otherwise normal. Her PT-INR was 1.6, so we suspected sepsis. And when she had a drain inserted, and the drain was removed by a junior person, and the tip of the drain, she made out that fecal matter is there. So we understood, we took importance of the PT-INR. Immediately she was taken for colostomy. She was rescued. And I heard that somewhere in Kerala, somebody had a frozen pelvis operated laparoscopically, and they missed bowel injury, the patient died on the second or third day. That is the problem. We don't listen to all these abnormalities. Thrombocytopenia, hyperbilirubinemia, ileus, bowel necrosis. And nowadays we always see the procalcitonin, which is more specific than CRP. This two standard deviation above the normal value is which is 0.2 nanogram per ml. It is a pooled sensitivity of 77% and specificity of 79% for sepsis in critically ill patients. The patient who had cholangitis and very high temperature, her procalcitonin was not increased. It was not. So it is not 100%. Muse is a bedside tool to identify patients at risk of catastrophic events, including sepsis, and developed in UK. And nowadays, I don't think. What about Aravind? Aravind, are you using this Muse chart? Because
madam, actually, we are not using this now, madam.
It is.
So for completion's sake, I will. Okay. So far, we have to do the investigations, and in SOFA, it's a simplified version of SOFA, which is done at the bedside to identify patients at risk of poor outcomes due to suspected infection. When the Q-SOFA is 2 or more, the patient is having full-fledged sepsis. So it cannot be used as a screening tool, but it can be used for prognostication. The patient meets 2 of these criteria, further for an infectious source should be conducted. Respiratory rate more than 22, altered mental status, and systolic blood pressure of less than average. And when it comes to pregnancy, we take the systolic BP as 90 because even a normal pregnant woman will have a lower systolic BP. And respiratory rate also will be usually higher than normal. So the respiratory rate of more than 25 is taken as abnormal. And this is one important thing which I would like to stress, because this Muse chart where all these vitals are recorded should be used by all the delivery points. And we have provided our modified Muse chart, and it should be made available in all the delivery points, and they have to use the Muse chart. Otherwise, when the patient goes into sepsis or any other problem, we can make out bleeding or any problem. So everybody has to use this Muse chart. That is the chart, and we have the KFOG modified Muse chart. A low score of 1 to 4, a medium score is 5 to 6, and a high score is 7 or more. Any single score of 3 indicates an extreme variation from the normal, which is considered at least a medium score. I told you about the PTINR. PTINR is high. The score should be taken as high. The color forms are green for a low score, amber for medium, and red for high scores. So the green pathway, the amber pathway, and the red pathway. And puerperium is another situation where infection, sepsis is common. Puerperal sepsis is infection of the genital tract because it's a very raw area where the placenta had been attaching. Fever, chills, and rigor, false smelling discharge. Every puerperal patient also should be very carefully examined. Very carefully, mother and baby should be examined. Tachycardia, subinvolution, abdominal pain, discharge, fever, to go through the. It's better to go through the Muse chart and make out. And that's why I'm telling all the delivery points should have Muse chart. So, as in any other branch of medicine, a proper history is very, very important. And clinical, we will come to clinical scenarios where proper history is not taken and we have landed up in sepsis. Clinical examination, laboratory tests, of course, will tell you whether the patient has sepsis or infection, only infection.
And of course, if it is needed, imaging findings. Like I told you about the cholangitis, which is diagnosed only by imaging. And sometimes it can be leftover foreign body, which can be diagnosed by imaging. That did not happen. Or an abscess along with pregnancy, which are all made out by imaging. And yeah, especially chest infection after 17 weeks, there's nothing to, we can take an X-ray test, which is actually 3 racks, which very well baby fetus can tolerate. So if there is a serious, you're suspecting pneumonia, we can very well take an X-ray or even CT if it is necessary. Coming to management, suspicion of sepsis should prompt an aggressive search for infection, including a thorough physical examination, inspection of all wounds, evaluation of intravascular catheters, obtaining appropriate culture and adjunctive imaging studies, as I already said. The initial resuscitation is very, very important. Sepsis is a time is life when it comes to sepsis management. Delay giving the initial strong antibiotic, you can lose the patient's life. And septic shock, a medical emergency, and the treatment and the resuscitation should begin immediately. Early identification and appropriate management after diagnosis of sepsis is the most important factor affecting the outcome. So every effort should be made to find out whether it is sepsis or not, and then treat. Suppose, for example, if it is suspected of having a massive pulmonary embolism, traumatic, then you can do a CT, contrast enhanced CT, and rule out pulmonary embolism and start her on antibiotic. There is controversy regarding it should be started and then examined, or should be CT should be done and then started. What about Dr. Arvind?
Madam, good evening, madam. Good evening, all faculty from KFOG. Thanks for giving me this opportunity. As madam said, the sepsis is becoming is a leading cause of mortality among during the pregnancy, intrapartum, and postpartum period. So here the problem is that in pregnancy, due to the physiological alterations is normally occurring in pregnancy, sepsis might have an insidious onset. Sometimes even fever may not be there. Since it is insidious onset, but it might only a trained eye may be able to diagnose sepsis early. The second aspect is that the patient might appear to be deceptively normal, but then the progression is going to be pretty rapid. He may not get time to act, especially the progression from sepsis to septic shock might be quite rapid. So in this context, the aim, if you want to bring down the mortality, maternal mortality due to sepsis, we have to adopt 3 strategies. One is we need to suspect sepsis at the earliest. For example, in this situation, if you have a doubt between, say, pulmonary embolism, which could be a DD of sepsis, and if there is a delay in taking CT angio, we know that the patients, the pregnant ladies might deteriorate quite rapidly. So my suggestion will be to draw blood culture, start on broad spectrum antibiotics based on your institutional antibiogram, and try to stabilize the patient and then go for CTPA. And if CTPA is showing a pulmonary embolism, you can stop the antibiotics. If you are adopting the other strategy, like, we are going for CTPA first and then based on that, we'll start antibiotics later, probably will be, all the targets are time sensitive, and in a septic shock, the right antibiotic has to be given within 1 hour of suspecting a septic shock. So that is very important, because every hour delay for the first 6 hours, the mortality is going to go up by 7.6% in non-pregnant patients. So in pregnancy, the outcomes could be deleterious. So there are a lot of DDs, like madam said, like a pancreatitis, say cholecystitis, or say a TTP, or HELLP syndrome, or SLE crisis, etc., which could mimic sepsis. So I think that we have to consider it as sepsis was start out with the sepsis bundles, and during that period, we should try to rule out other DDs. And if we actually clinch the diagnosis as some other DD, we can stop antibiotics. That will be my
Thank you,
opinion on
Dr.
that
Arvind.
situation.
Okay, great. Thank you, Dr. Arvind. Nowadays, this contraceptive, etc., are available in most of the centers. So there is not much of not much of delay. The other thing also should be properly treated, the massive pulmonary embolism. So there is no harm if you start your own antibiotics. That is the main thing. And then go for an angiogram, and it is pulmonary embolism. It has to be treated. Even massive pulmonary embolism nowadays should not die, because the facility for treating the massive pulmonary embolism is available in every nook and corner of Kerala. So we have to keep in mind sepsis and act accordingly. And that is the concept of bundle. 1 hour, we have to, very, very important, and measure serum lactate and remeasure if the initial lactate is more than 2. Obtain blood culture prior to administering antibiotics, and the blood culture should be 10 ml from each, 2 different sides. That means 40 ml we have to take. And we had a patient who had abdominal pain and distension the second day of laparoscopic surgery, and we were about to take this 40 ml, and the patient's husband resisted. That 40 ml blood cannot be taken. We were suspecting sepsis, and we did procalcitonin and lactate, etc., and excluded sepsis. It was not sepsis, but the patient relative also, patient's husband didn't give consent for taking this 40 ml. And another thing is rapid administration of crystalloid, 30 ml per kg, and it can be 20 ml per kg also in pregnancy, because we are scared of this lung injury. If there is hypotension and serum lactate is more than 4 millimoles, then we have to start this fluid and give it in 30 ml per kg and give it in another 3 hours. And use vasopressors if the patient is hypotensive during or after fluid resuscitation to maintain a mean arterial pressure of more than 65 millimeters of mercury. Mean arterial pressure of more than 65 only is an evidence that tissue perfusion is well maintained. And this we had a patient who was admitted with a premature rupture of membrane. A 40-year-old lady, twin pregnancy, IVF. She had leaking, and she was not willing to terminate the pregnancy because it was 24 weeks. And by one day, 11 p.m., we did the cesarean, and the next day, she was a bit restless. She was going to the bathroom, and she was telling that I want to pass urine. And then we told her we will catheterize, and we catheterized. But she said she wanted to pass motion, and then she was running to the toilet. But pulse rate was a little bit increased. No, temperature increased. But I was sensing something wrong with her. Something wrong. There was a premonition that there may be something wrong. So I asked the PG student to monitor the patient, be with the patient, and inform if there is a problem. And she, by 10 o'clock, she said, Madam, by 9:30 or something, she said, Madam, the urine output is a bit less in the past 1 hour. And her BP also fell some 10 millimeters of mercury. Then I rushed to see the patient, and she was going for sepsis. And we immediately shifted the patient to Phantom Medical ICU, and accompanied by a gynecologist and anesthetist. And I sent noradrenaline also along with them. In case she has BP fall, we had to start. Then reaching there, the BP was maintained, but reaching the ICU, she went in for hypotension, and she had to have 6 antibiotics, and we could rescue the patient, and we had one baby also was rescued, 24 weeks. Slide. ഇന്നെല്ലാം പ്രോബ്ലമാണ്. Slide is not moving, sir. Yes. That is a pictorial septic, 1 hour bundle. And some antibiotics are recommended within 1 hour of suspicion of hit heart. And MRSA suspected vancomycin planet should be started. Antibiotic, the instrument to decide. And Dr. Aravind, can you tell how there is sepsis? We are suspected. We have proved organ dysfunction. Which antibiotic we
Thank you.
should start?
Sure, madam. Thank you, madam. So basically, the selection of the right antibiotic is within the 1 hour bundle, ideally after drawing the culture. The first aspect has to be that, we need to identify the source of sepsis. So sepsis is, as madam has said, it is a dysregulated immune response to an infection, which could be a bacterial, viral, parasitic, or even fungal. So in pregnancy, we'll think about bacterial and viral. So we need to identify the syndrome that we are dealing with. What is the source of infection? It could be, say, a respiratory infection. It could be genitourinary infection. As madam said, it could be a complicated gastrointestinal infection like a cholangitis sort of thing, or it could be like a chorioamnionitis progressing to necrotizing endometritis sort of thing. So based on the clinical features, we need to have an idea about what we are dealing with, what syndrome we are dealing with. Next is going to be the predictable bacteriology. Suppose the patient is having a neurosepsis sort of thing, then we know what we need to cover. It could be, usually it is going to be E. coli or say Klebsiella, and if gram-positive, it is going to be streptococci. Like that, no, if you are suspecting a chorioamnionitis, which is later progressing on to say endometritis or something like that, it is going to be polymicrobial, where we need to cover the gram-negative bacilli, gram-positive as well as anaerobes. So basically, based on the predictable bacteriology, we are going to select the right antibiotic, and with patient is in sepsis or septic shock, we need to get it right. So within 1 hour. So basically, we need to cover this gram-positive, negative, and anaerobes as well. But if you are starting with drugs like say piperacillin, tazobactam, ceftazidime, sulbactam, etc., those drugs do have very good anaerobic coverage as well. So metronidazole may not be required. And second aspect is we need to look at whether the patient is likely to have a community-acquired infection or a hospital-acquired infection. Because in hospital-acquired infection, so the resistance profile is likely to be different based on your institutional antibiogram. Some hospitals might have more of MRSA rates. So basically, if you think that's a healthcare associated infection, MRSA coverage would have to be started upfront itself. So how do you decide on whether the patient requires a broad spectrum coverage and not, and whether the patient is likely to have a healthcare associated infection? That is based on a lot of factors like whether the patient has been hospitalized for a prolonged period of time. Have you done any interventions? Was the patient on, say, catheterization, Foley's catheter, etc.? Was the recent surgery performed? Or patient has the patient taken, say, antibiotics within the last 90 days, etc. In such case, in gram-negatives, the chance of it being an ESBL organism is pretty high. In case of gram-positive Staph aureus, the chance of it being an MRSA is also high. In such situations, we have to go for combinations like say piperacillin, tazobactam with vancomycin, etc. So we are suspecting a healthcare-associated infection. The next will be optimizing the pharmacokinetics, pharmacodynamics, and toxicodynamics of the drugs used. For example, suppose as part of sepsis, patient is having an acute kidney injury sort of thing, you have to modify the dose and all. So basically, the selection of antibiotic is based on the clinical syndrome identified and predictable bacteriology, and whether it is a community-acquired infection or healthcare-associated infection. And then ultimately, it will be like optimizing the dose of antibiotics. And most important aspect is that antibiotics alone is not actually going to ensure very good outcomes. You need to identify the source of infection, and if the source reduction is required, so if there is a devitalized tissue or abscess, the tissue has to be removed. That is, debridement is essential. Abscess has to be drained. So without addressing the foci of infection, antibiotics alone may not have the optimal outcomes.
We'll come to it through the clinical scenarios, Aravind.
Okay,
So that is, and if it is respiratory infection in pregnancy, we have to give her oseltamivir. Unless you start it early, she can go in for severe respiratory failure. And I think for gram-negative infection is suspected, it's better to give 2 antibiotics, isn't it, Dr. Arvind? Starter or 2
Madam,
antibiotics.
suppose you are using ambigenda, etc., 2 antibiotics are required. But
Okay.
in many centers, if they are suspecting sepsis and all, they are going upfront with piperacillin tazobactam. So in such situation, 1 antibiotic will be enough, madam.
Thank you. Sepsis can be, when the patient collapses, sepsis can be proven, sepsis can be suspected, but we have to give as already mentioned, there should be a low threshold for commencing antibiotics and IV fluid also. Even if she is in renal failure or cardiac failure, we can start IV fluid and then decide. And the pregnant woman should be managed in the left lateral position to avoid the aortocaval compression. And I already said about taking the sample, one of the bundles, CRP, procalcitonin, liver function, renal function, and the swab also, swab and culture. That is after tackling the initial hypotension and giving the antibiotic, within 6 hours, the BP is not coming. I mean, still BP fall is there. We have to administer vasopressors. If she has hypotension, to maintain a mean arterial pressure of 65 millimeters of mercury, which ensures good tissue perfusion. And norepinephrine is the first choice. And vasopressin is not recommended as an initial agent, but you can add if she's not responding to noradrenaline. In the presence of myocardial dysfunction, then of course, in spite of all these, then of course we can think of giving dobutamine. Previously, dobutamine used to be started initially, but now it is after noradrenaline and vasopressin. But serial measurement of lactate, if initial lactate was elevated, because we would then we can make out whether she is responding to the present antibiotic or not. It has to be measured every 2 hours. And coming to continued fluid administration, should be carefully assessed intravascular volume status on the one hand and fluid overload on the other hand. When we go through many of the maternal deaths, we find that it is fluid overload that caused the maternal death. And that is why the patient is in septic shock. She should be ideally managed in an ICU setup. And volume responsiveness should be guided approach should be resorted to. Heart rate, CVP, and systolic blood pressure are poor indicators of fluid status. IVC compressibility by ultrasound. If the IVC is not compressible, she has good intravascular volume. And non-invasive, there are at present non-invasive methods like methods of seeing the stroke volume and cardiac output. And in our institution, we don't have it at present. What about Dr. Aravind? You have this non-invasive method of measuring stroke volume and cardiac output?
Madam, in our multidisciplinary ICU, they have all these facilities, madam. And they are adopting only IVC collapsibility based resuscitation to avoid fluid overload in patients with sepsis and septic shock.
Thank you. And if it is needed beyond repeated small doses also is a good measure, means to prevent overloading the circulation. If that is not possible in limited settings, more than 15% increase in the pulse pressure indicates fluid responsiveness. Capillary refill time, that is actually very, very good in assessing the intravascular volume. That anybody can assess. And I think it's a very good sign of tissue perfusion that all of us can do. It should be augmented by careful, frequent, and comprehensive patient evaluation. Everything should be comprehensively evaluated, whether the lung is normal, whether the saturation is normal, whether the BP is normal, whether she has a good output. So all these together we have to see, and fluid management is very, very important. And we have seen that sometimes because of the fluid management, death occurs. For example, she is rallying around after a septic shock. You find that the hemoglobin is 8 grams per cent, or the platelet is 40,000. Then we need not give her platelets. Surgery is over. She is not a chance of bleeding. Then we need not give platelet. We need not give PRBC, because all these are all this will increase the oncotic pressure, which is good, but it will increase the hydrostatic pressure as well. And we have seen that in many cases, it is being unnecessarily given. That's why we repeatedly telling that it should be given only if indicated. And maintain a mean arterial pressure of 65 millimeters of mercury, and more than that, don't try it, because we give a lot of vasopressin, it can cause atrial fibrillation. And antifungal therapy sometimes may be necessary in mixed infections. I don't know whether I don't have a experience of giving antifungal. What about Dr. Arvind?
Madam, that is in select situations like, patient because of sepsis or septic shock, is in the ICU, is ventilated, is having a central line, request TPN, etc. In such situation, as a secondary infection, candidemia is possible. So we have Candida score and all. Candida score actually looks at 4 factors. Septic shock, there is 2 point. Then history of a GI surgery, there is a 1 point. Then TPN, there is 1 point, and multifocal Candida colonization. This applies to all the sick patients in the ICU, including the peripartum sepsis or pregnant ladies with sepsis, madam. So based on the Candida score, if it is more than 2.5, we'll empirically start the patient on antifungals, fluconazole or capsopengine, based on the whether the patient is in hypotension or not. And the yield of Candida from blood culture is around 40 to 50%, madam. And based on that, we can optimize the treatment. So we use Candida score to preemptively start those patients on antifungals.
So that's why a patient should be managed in an ICU setup. So coming to indications for transfer to ICU, hypotension, pulmonary edema, which should not be made worse by your IV fluids, renal, she needs dialysis, CNS, if she is consciousness is decreased, or she is in multi-organ failure, uncorrected by all these means. And indications for ventilation, if she is in hypotension, she has severe respiratory efforts, then of course she needs to be intubated and ventilated. And when she is ventilated before extubation, the criteria should be met before extubation. Make sure that the criteria for extubation is met before extubation. That's very, very important. And in chorioamnionitis suspected, the fetus should be delivered. In extreme cases, hysterectomy may need to be considered if myometrial necrosis is the source of infection. I did one hysterectomy for a nullipara because she had sepsis. She had a enlarged uterus. It was long back. Enlarged uterus because of multiple fibroids, and the pregnancy was in almost in the fundal region, which is above the umbilicus. And somebody told her the pregnancy has to be terminated. And in spite of advice, somebody tried evacuation, because it's very difficult to manipulate. I'm telling all this because it should not happen again. It's very difficult to manipulate the cannula if you try to terminate pregnancy in the midst of multiple fibroids. So she couldn't complete the evacuation. And I was called. I also tried. I couldn't complete the evacuation, but she was kept in the hospital. She had very high temperature, and that time the antibiotic available was ceftriaxone, and we gave ceftriaxone. She didn't respond. I opened the abdomen. I found that the myometrium is necrosed. So I had to do hysterectomy for a patient without any children. So these type of situations we should not create. Non-obstetric sources of infection should be borne in mind and include appendicitis. When she comes with pain abdomen, it could be an appendicular mass, it could be pancreatic abscess, it could be cholecystitis, or it could be an infected bowel. We have to think about it. And always take a culture and know the bacterial sensitivity of the infected tissue. If it is she delivers after premature rupture of membranes for several days, then of course you can send the amniotic membrane or the fluid for culture to know the sensitivities. And if she is not responding to any of these measures, then of course we can't think of giving IVIG. Severe invasive streptococcal or staphylococcal infection or when other antibiotics have failed. IVIG has an immunomodulatory, especially in staph infection, streptococcal infection, it neutralizes the superantigen effect of exotoxins. And I remember one patient who died long back after this premature rupture of membrane. Several days she delivered, and the next day she had rashes all over the body, and the evening she died. So it might have been a streptococcal infection. And those days, these newer antibiotics were not there. And if they had been there, we could have given the new meropenem or something like that. And if she's still not responding, we could have thought of giving immunoglobulin. And nowadays we have these options, and we have to think about it. And coming to Dr. Arvind has already said, sepsis, first anywhere, first you have to evacuate. Whether it is in the abdomen, whether it is below the diaphragm, whether it is in the pelvis, whether it is in the thorax. We recently had a patient who had very high temperature following delivery. She was obese, she was diabetic, and she had cesarean, and she had respiratory infection. She had biothorax. And that was evacuated. She had thoracotomy and evacuated. So pus anywhere, it has to be evacuated, whether it is in the thorax, whether it is in the abdomen, whether it is in the around the appendix, wherever it is. And sometimes, as I already said, hysterectomy may need to be done. If it is necessary, we may have to do it to save the life of the patient. And this is a picture of necrotizing fasciitis, where the infection occurs within hours or within minutes. So we have to debride the wound as an emergency, start her on a strong antibiotic, which staph and streptococci will respond. And previously, for all septic abortion patients, we used to give corticosteroids, very high dose, 1000 milligram we used to give. And nowadays, we need not give, we should not give. And if the BP remains less than 90 millimeters mercury, despite all these measures, then of course we can think of hydrocortisone 200 milligram per day for 7 days in 4 divided doses. What I have to stress in this situation is that whenever a patient comes with pain abdomen, without taking a proper history, without doing a proper examination, because she is 30 weeks, you give her steroids. Don't give steroids. I daily, at least once I used to say, unnecessarily steroids should not be given, because it is for lung maturity protection of the fetus. But it is needed if you are planning your delivery and if she doesn't have any infection. It will cause flare-up of infection. So don't give blanket steroid. Take a proper history, do a proper examination, and if it is preterm contractions, then of course you can give steroid. Otherwise, don't give. Please don't give. So coming to steps for prevention is better than cure, and we have to be using sterile precautions, hand contamination, frequent use of alcohol gel, availability of infection control guidelines. And your team should be trained. And empowering your team is one of the responsibility of the doctor or the obstetrician. We have to train our team, especially in the labor room or the wards. And use of modified early warning scoring systems, the Muse chart. So we should insist that they have to fill the Muse chart, because at a glance you can make out that the patient is okay or not. And involvement of the infection control surveillance teams to monitor progress in every institution. That is a sterile delivery set. So I think everybody is using the sterile delivery set. We can afford to, because Even the grade 4 laborer, daily laborer, the remuneration given is some 1,500 rupees. So we have to insist that everybody uses this disposable delivery, sterile delivery sets. And in government institutions, in all the levels of government institutions where delivery is being conducted, it's given free. There should be dedicated pre-prepared PV sets. Vaginal examination should not be done without washing hands and wearing sterile gloves and preparing the area. Pre-autoclaved delivery sets should be there for all the deliveries. Hand cleaning with scrubs before each patient. And proper hand washing techniques in OT. In OT should be actually in UK and other developed countries, the OT scrubbing is scrutinized through camera. That is what my daughter tells. Because you should take 5 minutes for the initial wash. Avoid antibiotic misuse. That's another thing which I like to stress, because for every now simple reason, piperacillin tazobactam is being given. So antibiotic resistant strains will be common. Antibiotic stewardship, which Dr. Aravind will tell you later. There should be an accuracy approach to sepsis if sepsis begin, which I have stressed several times. We'll come to certain clinical scenarios. 28-year-old Gravida 2 para 1, GDM on insulin, who had previous cesarean, underwent elective cesarean delivery. Post-operative day 4, she developed fever, wound culture grew staph aureus, and she was started on piperacillin tazobactam. On day 9, she had abdominal distension, fever, and breathing difficulty. On arrival at the tertiary center, she had abdominal distension, abdominal wall edema, ultrasound revealed moderate ascites with internal leucos, which is pus. And that's why you say all gynecologists, all obstetricians should learn how to do ultrasound, how to make out whether the fluid or blood or whatever is inside, any other pathology inside, and apart from knowing about the fetus and placenta. And she had bilateral pleural effusion. Her fever did not subside. CACT on day 14 showed loculated ascites. Previously, ultrasound showed moderate ascites. And laparotomy on day 50 drained pus and performed a peritoneal lavage. Despite adding meropenem and vancomycin, she expired. There's actually a lot of delay in opening the abdomen. There should not be any hesitance to open the abdomen if it is necessary, whether it is blood or pus. If it is deemed necessary, we need not hesitate to open. If it is an internal hemorrhage, open the abdomen and do what is necessary. And if it is pus, you drain the pus. So that should be done. Dr. Aravind stressed, no, wherever there is pus, we have to drain the pus. So here the delay in laparotomy and starting meropenem and vancomycin, she died. Coming to the next scenario, 33-year-old Paini, married like 5 years, ovulation induction conception, 18 weeks, 4 days, overt diabetes mellitus, OHA, oral hypoglycemic agent. She was referred from local hospital. She already had 3 days of leaking and came to the hospital. And she was treated with injection amoxiclav for 3 days. Her TC was 13,700. And in view of patient request, she was referred. On arrival, patient was conscious and oriented. She had a BP of 120/70 and pulse rate 98. SpO2 was normal. And it was IUD. And after IUD, she was, abortion was induced. And after abortion, she was started on piperacillin tazobactam. Because the TC was 17,100, CRP was 14, LFT, RFT, electrolytes were normal. And later on, she expelled the fetus, and post-expulsion, patient was stable, no symptoms. That is what is written. Vitals, pulse rate 106, BP 90/70. Previously, she had 120/70. And saturation, of course, was 98%. She was shifted to the ward. And from the ward, she had breathlessness, chest discomfort, full-fledged sepsis. pulse rate 121, BP 70, 40. She should not have been shifted to the ward because she had BP ward, she had tachycardia, and she is a patient who had premature rupture of membranes in several days. So no order need to be started, but somehow she was saved. She responded to meropenem. 40-year-old next scenario. 40-year-old gravida to para previous cesarean with GDM, anemia corrected, underwent elective cesarean with sterilization because of previous cesarean. Developed sudden onset of blood pressure. See, sepsis can occur already sudden and mimic massive pulmonary embolism or some other crisis. She had abdominal distension on day 4, tachycardia, tachypnea, and homotency, but SpO2 is maintained. And D-dimer was high, bilateral lower limb venous Doppler, CTPA, everything done. Maybe she started on antibiotic after doing all this. And USS abdomen, uterus normal, postpartum status. TC was elevated. There was thrombocytopenia. And patient was shifted to ICU. 120 pulse rate, BP 160, 110. So magnesium sulfate was given because he had a BP of 160, 110. She was started on diuretics, meropenem, later hiked to teicoplanin. Central line place, blood and components transfused. 4 units platelets, 4 units FFP, 1 unit PRBC. This is what I said. This was actually unnecessary. Serum is already over. Post-operative day 4 or 5 it is, and she has no bleeding. And why should she be given platelets, plasma, PRBC? She developed hypotension and required triple inotrope and ventilatory support. She developed cardiac arrest and she died. One hour bundle should have been initiated, and all these CTPA, etc. She might have taken some time, and we should have suspected the infection and started the 1 hour bundle early. And I think her lung collapsed because of all these fluids. What do you say, Dr. Arvind? Are you listening, Arvind?
Yes, madam. Yes, madam.
Uh,
Yes, madam. Actually,
I think this component transfusion, platelets, FFP, PRBC, that was unnecessary. And maybe she needed inotrope and ventilator support because of the pulmonary edema. That's what I feel. This is the socket reason. I was asking your opinion.
I agree, madam. Yeah. Madam, in the first case, actually, when they isolated Staph aureus, the drug of choice for MSSA. So we need to discuss with microbiologists and see whether it is a medicine susceptible Staph aureus or MRSA. So I believe it was MSSA, and for MSSA, the drug of choice is not piperacillin and tazobactam. It is either cloxacillin or cefazolin. So that was something which could have also been done in the first case, along with aggressive source control. Second case, we were a bit lucky that the meropenem did work and all. In this case, as madam suggested, we should have been more focused on the guided administration of fluids, etc. So that the lung protective strategies
And,
could have been adopted.
the comprehensive approach should be taken. That's why. Next scenario, I think everybody is getting bored. The next scenario, 37-year-old lady, gravida 3, para 1, previous cesarean, developed acute onset to diffuse, continuous. This is very interesting. All of you should listen. Continuous abdominal pain and associated abdominal distension, nausea, constipation. She was 32 weeks pregnant. She got admitted at local hospital and suspecting preterm labor. She was treated with antenatal steroids and duodenal drip, but her symptoms were not relieved. She was referred to us. And when she reached here, she was very sick looking, restless, dyspneic, but conscious and oriented, very much dehydrated, febrile, tachycardia. BP, of course, was 120/70. Respiratory rate was 30 per minute. Or taking a history, the history was that she had pain, abdomen, and distension and vomiting. So, and it was a continuous pain, not an intermittent pain, and not, definitely not labor pain. So I tried to examine her. She was not allowing me to touch, and the rail anesthesia was working. I immediately sent all the investigations, and uh, ultrasound also immediately done. And there was a suspicious mass in the region of the appendix. We took up the patient for laparotomy and a vertical incision. We put a vertical incision and laparotomy. Pus was in the abdomen, and we did cesarean also, and it was found that she had an appendicular abscess. So for this appendicular abscess, she was given duodenal steroids. That is why I'm telling, whenever a pregnant patient comes with pain abdomen, always see whether it is labor pain or not, uterine contraction or not, or any other thing like this with before giving steroids for lung maturity and duodenal drip. So take a proper history, do a proper examination, and if necessary, imaging, and sort out the situation. And this patient, we cleared the pus. Appendix could be removed, and the abscess was drained, and a drain was inserted, and she was started on penicillin tazobactam and metrogel, and which was given 6 hourly after surgery, because an intraperitoneal infection needs a 6 hourly dose. What do you say, Dr. Aravind?
Definitely, madam. Actually, piperacillin tazobactam, the minimum dose is 8 hourly, and if you're suspecting septic shock, etc., it should be 6 hourly, madam.
And this is the next scenario. 40-year-old previous surgeon referred from periphery to the tertiary center in view of severe preeclampsia, deranged epilepsy at 37 weeks. And her weight was 107 kg. Hypertensive, diabetic, 40 years. So all these risk factors. She should have been referred earlier. She should not have been in a primary care setup. She should have been referred early. And whenever these obese patients come for antenatal checkup, even in the first antenatal checkup, we have to tell her, try to do some exercise, especially respiratory exercise. And her weight gain should not be more than 6 kg throughout pregnancy. So give her a diet plan, if possible, consult a dietitian, because she is at very high risk for infection, diabetes, hypertension, all these complications. She underwent category 3 LSES in the tertiary center, delivered a female baby, and then what happened? Started on non-invasive ventilation. She had to be on, she had desaturated and started on non-invasive ventilation. Echo showed good LV function. Everybody might have suspected some pulmonary embolism, but it was not pulmonary embolism. And she had cardiac arrest on day 6. And her lung was collapsed. There was mucus plug when bronchoscopy was done. And MRI brain showed, her MRI brain showed tonsillar herniation suggestive of type 1 Arnold-Chiari malformation. This type 1 Arnold-Chiari malformation has been there even from her birth, because of which she didn't die. She died of sepsis. So this MRI misled the obstetrician. You should not be misled by these ancillary findings. What should have been done was lung lavage and culture and proper antibiotic, proper dosage, proper duration. About this patient, bronchoscopy showed mucopurulent secretion right lung, but her sepsis was not properly managed and she died. She was referred to a neurologist, but the sepsis was missed. So it should be a comprehensive approach to the patient. So I think this is the last scenario. 27-year-old Gavida 3, para 1, 39 weeks. previous FTMD. She had recurrent UTI. Urinary tract infection is one source of sepsis. She was admitted and induced with Foley's catheter, delivered the next day, and was on ampicillin. On the fourth day, patient had fever spikes. Bowel sound sluggish, gross ascites, bilateral hydroureteronephrosis. She was started on Piptas, consulted nephrologist, RFT deranged, urea was 100, serum creatinine 5.3. They suspected HUS, hemolytic uremic syndrome, or sepsis. Next day, sustained low efficiency dialysis was done. She was started on noradrenaline. She was, of course, shifted to ICU, put on ventilation, co was normal. Urine culture as Klebsiella, CT done, paralytic ileus, pleural effusion. She was started on TG cycline, colistin, ascitic tap, shock, pus, and laparoscopy done, lavage done, and she was rallying down, shifted to the surgery side. A patient improved, right side drain removed, a pleural tap done. And something happened after this pleural tap. She actually died on the 35th day or something. Actually, it was urosepsis, pelvic abscess, peritonitis, and multi-organ failure. So when the patient is, such a patient is coming up from the situation, she should be properly followed up. She should be properly followed up, because because she can again become bad after this initial rally. So ascitic fluid culture on postnatal day 5 had shown Klebsiella, but drainage took another 11 days. Earlier intervention to remove the source of infection should have been done. So to think about the patient, even if it is, even if the urologist is consulted, this patient made a recovery and then worsened, which shows the need for continuing care and monitoring of such sick women. We are not sure whether the cause for the final collapse is thromboembolism, but still, this all these sepsis could have been prevented by proper antibiotic, or if it is when they found that ascitic fluid culture is positive, draining the pus. That this is the last scenario. Primary induced labor with Foley's started on cefotaximum and metrogel. There was an intrapartum temperature spike of 101 degree. Emergency LSCS was done and co-failed induction, maternal pyrexia. Then again, she had another temperature spike and she was given ceftriaxone and Tamiflu, and thromboprophylaxis also was initiated. Again, she continued to have temperature spikes. A blood and urine sent for culture. She had abdominal distension, serosanguinous discharge, antibiotic hike to Piptas. Ultrasound of the pelvis, mild fluid with internal echoes. And surgeon was consulted, antibiotic hike to meropenem. And this culture yielded heavy growth of E. coli. And she continued to be febrile. Meropenem continued. Normal limited. Albumin was given because the albumin was less. CT abdomen showed fluid collection noted in the anterabdominal wall. An emergency laparotomy done. Yellow serous fluid from the parietal wall behind the rectus sheath, pre-peritoneal space, minimal peritoneal fluid, peritoneal cavity contained only less fluid, and pus was sent. It was MDR, Klebsiella, and E. coli. 4 traits were placed. So these are all clinical scenarios which I took from the near miss and maternal death review meetings. To conclude, sepsis is a significant contributor to maternal mortality, and early diagnosis and initiation of treatment is the most important factor affecting prognosis. Antibiotic misuse should be curbed. Once sepsis is identified, hit hard with broad spectrum antibiotic. Antibiotic may need to be escalated or sometimes de-escalated or even stopped depending upon the need. Because, for example, after giving antibiotic, we do a CECT and find it is massive pulmonary embolism, we can stop the antibiotic. And fluid management is very, very important in treating the septic shock. And methods of preventing infection should be given very importance, and let us together make every delivery point safe, both for the mother and the fetus. Dr. Aravind, tell us something about antibiotic stewardship.
Thank you, madam, for taking us through the aspects of sepsis and how to prevent it in a very detailed fashion. Regarding antimicrobial stewardship, fortunately, as far as the obstetric practice is concerned, in majority of the infections are susceptible to our up to the carbapenems it is susceptible. But in the adult, in the non-obstetric side, our real problem is that majority of the patients in the ICU are resistant to carbapenem. For example, the state publishes the antibiogram every year, and the susceptibility of Klebsiella isolated in the ICU to carbapenems is only around 50%. So 50% of the case of Klebsiella infection in the ICU is resistant in the non-obstetric setting. The Acinetobacter infection, 60% is resistant. E. coli, 10% resistance. Pseudomonas, 20% resistance. And this varies from institution to institution. So this is going to be our future if we are not very careful with antimicrobial stewardship. As of now, the obstetric patients, the majority of them are having community-acquired infections. But you can see that in cases where interventions were done, ultimately the infection turned out to be MDR Klebsiella, requiring tigecycline, colistin, etc. So if we want to avoid this situation from occurring in obstetric practice, we need to be very, very focused in the use of antibiotics, and we need to stick on to the principles of antimicrobial stewardship. We need to select the right drug at the right time, right patient, right dose for the right duration. The right duration is also important, as madam said. If you are, we need to look at IOs, that is, start smart and then focus. If you are able to find a non-infectious source of to account for the worsening of the patients, we can stop antibiotics. There is nothing like completing the full course of antibiotic now. It is actually start smart and then focus, and the dictum is shorter is better. For example, even for a complicated appendicular abscess, there is an appendicitis which has ruptured. If the source control is adequate, you require only 4 days of antibiotic. That is a stop it trial. So that can be extrapolated to all the gynec infections or obstetrics infections as well. If the source control is adequate, the patient is clinically stable, hemodynamically stable, a short course of antibiotics is as good as a long course of antibiotic. When you're looking at the obstetric practice, there are a lot of situations where we can actually practice antimicrobial stewardship. One is in the use of metronidazole. When we are using ambigenda to cover for our intra-abdominal infection, definitely we need to add metronidazole as well, because we need to cover the anaerobes. But in many centers, the moment you are suspecting a complicated intra-abdominal infection, they are either starting piperacillin tazobactam or cefoperazone sulbactam. Both these antibiotics have excellent anaerobic coverage. So there is no added advantage in adding metronidazole. But obviously, we know that in case where there is a chorioamnionitis or endometritis, etc., probably we are not really confident about the anaerobic activity of piperacillin tazobactam per se. In that situation, add metronidazole, but not for 5 to 7 days. After 2 days, you can stop it and you can continue with piperacillin tazobactam or cefoperazone sulbactam. And regarding the IPC aspect, preventing an infection from occurring is actually much, much more easier than actually treating a drug-resistant infection later on. So basically, our onus has to be on IPC practices and antimicrobial stewardship. And the global program on sepsis was launched a couple of years back. And their target is by 2030, the maternal sepsis and neonatal sepsis, the deaths should come down by 20% by adopting the sepsis care bundles as well as the sepsis pathways. And one of the most important aspect of that is actually optimizing the infection prevention control and infection prevention control practices in all the obstetrics. That is the labor room, etc. So that is from my side, madam. Thank you very much.
Thank you, Dr. Aravind. So I think everybody who, I don't know how many have logged in.
Only some
ആരെയും
225, madam. Only 225.
There are more than 2,000 gynecologists in Kerala. And Dr. Subha joined now only.
No, no. Sorry, ma'am. I was there throughout, on and off in between. When the video was on and off in between, ma'am. Very
On and
nice
off
one.
you went for laparoscopic surgery.
No, no. I am in Calicut. We have a live. We have a offline meeting also, madam.
Okay. So I
Very
think
nice, ma'am.
every
Madam,
practicing of.
We have two questions, ma'am. We have two questions,
Yes.
ma'am. One is, ma'am, 38 weeks pregnant lady, ma'am, with UTLA, Klebsiella sensitive to cephalosporin, sulbactam. Antibiotics was started, and the patient developed fetal distress on the 4th day of antibiotics.
So what? To deliver the baby.
Okay, ma'am. Okay.
If it is sepsis, if there is sepsis, it's better to deliver the baby. Otherwise, baby can go for IUD.
Good evening, Jyoti madam. Good evening, Jyoti madam.
Jyoti?
മാഡം എനിക്ക് ഡെലിഗേറ്റ് ലിങ്കിലായിരുന്നു ഞാനിത് വരെ ഇപ്പോ സുഭാഷ് അയച്ചതാ.
അല്ല ഞാൻ സജലയ്ക്ക് കൊടുത്തിരുന്നു പിന്നെ ഫാക്കൽറ്റി ലിങ്ക്.
Suchitra madam, Madam Suchitra madam, can you just unmute? Yeah.
I had sent it to Jyoti.
ഞാനേ സജലയ്ക്ക് കൊടുത്തിരുന്നതാണ് ഫാക്കൽറ്റി ലിങ്ക്. പിന്നെ നിങ്ങൾ ബിസി ആയതുകൊണ്ട് നിങ്ങൾക്ക് തന്നേക്കാൻ പറഞ്ഞു.
ഞാൻ വൈകിട്ട് അയച്ചു കൊടുത്തിരുന്നു മാഡം. ഡെലിഗേറ്റ് ലിങ്കിലാ കയറിയെന്ന് പറഞ്ഞപ്പോ ഐ തിങ്ക് ആ മെസ്സേജ് കണ്ടിട്ടുണ്ടാവില്ല.
ഞാൻ നേരിട്ട് അങ്ങ് അയച്ചാൽ മതി.
Madam, there is one more question, ma'am. Role of colloids also, ma'am. Role of colloids.
Depending upon the need, no colloids. Why do you want to give unnecessary colloids? She has a hepatic failure and bleeding. Of course, you may have to give fresh frozen plasma. Otherwise, there is no need.
Okay, ma'am. Ma'am, there are two more just very small questions, ma'am. How to select the antibiotic? It's a very, very basic question, but then how do we select the antibiotics?
That is what Dr. Aravind has been telling it throughout. It should be a broad spectrum, and we usually prefer piperacillin tazobactam, and as Dr. Aravind said, it is methicillin MRSA, then of course vancomycin.
Yeah, thank you, ma'am. Arvind sir. Arvind sir, there is a question to you. There is a question to you specifically, which says, how do we de-escalate? How do we de-escalate the antibiotic? Is it based on TC by DC, or is it based on the marker, sir? How do we de-escalate, sir?
Actually, the de-escalation can be done in 3 ways. So basically, the easiest one will be a culture-based de-escalation. So you are starting with a broad-spectrum antibiotic for a suspected sepsis or a septic shock. And then, so if you are sending, say, 40 ml of blood, as madam suggested, and by around, say, 72 hours, you will get an idea regarding the pathogen. And based on the susceptibility, you can de-escalate. There is a culture-based de-escalation that can be practiced. The second aspect is that actually the culture is actually sterile. Probably the patient was referred to you on antibiotics and the culture is sterile. Then we can actually look at actually clinical stability grading can be adopted. Hemodynamic stability, and the patient is appropriate for say 48 hours. And if you have an alternate diagnosis other than sepsis, you can actually stop the antibiotics. So that is a clinical based de-escalation. Third is actually a biomarker based de-escalation. Biomarker for this, we will be using a procalcitonin. Procalcitonin can be used for de-escalation, but it has not been tried in obstetrics and gynec population for de-escalation. But we have enough data from the COPD cohorts, etc., that it can be used for de-escalation purpose, not for starting antibiotics. So probably the patient is clinically stable, hemodynamically stable as well, appropriate, and then the procalcitonin level is less than 0.5, or if there is an 80% decline in the procalcitonin level from its peak,
initial
then
level.
we can actually, initial level, peak level, we can actually de-escalate based on the biomarkers. So this is something we known as the IOs. That is, you are starting on antibiotics, and 48 to 72 hours based on the clinical features, you can either de-escalate antibiotics. Sometimes escalation might be necessary. So you may be able to stop the antibiotics if you are having an underdiagnosis like embolism or something like that. or you can also consider IV to oral switch. That is also important because the longer you are putting the patient on IV antibiotics, the chance of thrombophlebitis is there. So certain drugs are very good oral bioavailability. So in such situations, and if the patient is stable, we can go for an IV to oral switch action. And all possible scenario, go for a very short duration of antibiotics. Even in gram-negative sepsis, now we have RCT evidence showing that 7 days is as good as 14 days, provided the source is controlled. The majority of the cases, Madam had discussed, the important thing was the source control was not optimal, and when done, it was done a bit late.
Okay. Thank you, sir. I think the next question you already partly answered, sir, is the question is that now in a normal pregnancy, the physiological levels of leukocytes is also very much normal. So how do we depend it as a marker? I think you've actually cleared it out, sir. The next question is this, sir. I'm sorry because we're taking time, but a few more questions because this is such a nice webinar. A lot of people have got a few more questions we'll take, sir. Is how do we give IV immunoglobulins in this, sir?
Okay. IV immunoglobulin is indicated in a situation where you are suspecting a eye gas, that is invasive group A beta hemolytic streptococcal infection, where actually the symptomatology is based on the toxin and the deterioration is going to be quite rapid. So in such a scenario, we have some evidence to suggest that these immunoglobulins are going to help you.
Okay, sir. So the next question which we have is, now it's a very hypothetical question. In a case which is obese and actually in a very obese case who is not for an obstetrics but rather for a gynec case, why don't we start straight away peptides or piperacillin tazobactam? I think that we should desist and we should not actually. I think if I make an answer for this.
Actually. That is what we have been telling till now.
Yes, sir. So the next question, sir, is why not linezolid in MRSA bacteremia, sir? Why not linezolid?
Actually, for bacteremia, we would like to start with a Sidal antibiotic upfront. So vancomycin is Sidal and linezolid is static for MRSA. So that is the only reason why we would like to prefer vancomycin. And the evidence in pregnancy, in first trimester, second trimester, etc., vanco is going to be safer than linezolid. Because linezolid is a category C drug in pregnancy, whereas the vancomycin will be a category B drug in pregnancy. But suppose patient is having allergy to vancomycin, then we will go with teicoplanin instead of linezolid. In case where teico is also a problem, then obviously you can go with linezolid because NICE guidelines say that even though static, linezolid is the second option, even in bacteremia.
Sometimes in post-operative infections, we have seen that linezolid, actually we see a lot of patients who are put empirically on linezolid. So they respond pretty well, sir. If the first line antibiotic has not worked out, especially in laparoscopy as far as I'm concerned, sir, we have a lot of infections that come down to secondary infections, sir.
Yeah.
Linezolid does help out quite a lot, sir.
Linezolid is a very, very good drug, but the question was on bacteremia.
Bacteremia, sir. Bacteremia, sir.
So bacteremia vanco is actually better than linezolid. But for a surgical site infection, for pneumonia, etc., linezolid is as good as vancomycin, but we need to keep one thing in mind. Linezolid is a reserve antibiotic. So
Absolutely,
WHO has
sir.
classified antibiotics into access, watch, and reserve. So whenever possible, we should desist from using
Desist from using. True. Totally agree, sir. Totally agree.
It's a reserve antibiotic, whereas vancomycin is a watch antibiotic.
Linezolid is the most misused antibiotic. Left and right, everybody gives linezolid. So that also should be covered.
The next question is actually a testimony to whatever you've taken in the last 2 hours. Some of them have really taken over a lot of good things which you've said. And this is a question from Dr. Anjana. Sir, QSOFI, MEWS, can you pragmatically introduce these to find out the sepsis at the earliest if kept together in a pregnant woman? So sort of happy that many of them have followed whatever you have said, sir, in this, in terms of the classification. But the question is to you, sir, and madam, sir.
You can pick up if you are routinely using this Muse chart. And then you have to see, when you find that Muse chart is abnormal, you order for all this liver function, kidney function, PTIN. Then if you find anything abnormal, then it is sepsis. Then you have to give the strongest antibiotic. So that is the way you go. Yeah. For screening, Muse chart is good. SIRS is good.
Madam.
But for management.
Yeah, Dr. Arvind, you are saying something, sir?
Actually, it's not very easy to teach the clinical intuition to the younger doctors, right? So the
Absolutely,
replacement of
absolutely.
clinical intuition
Very
is
good.
this mu score and the Q
The
score.
clinical intuition, if I may add, sir, is very, very lacking nowadays. Even in the middle-aged doctors like me, sir, I would say. So I would not be wrong to say that, sir.
That is
I
why
think we have to.
all the scoring systems came in. We cannot teach them intuition, right? But then we can teach them the scoring systems.
Right. Sir, last but one question, sir, because we're getting a lot of questions. One is, sir, is the fluid that we give is ringer lactate. Will it affect the lactate levels for diagnosis in sepsis?
Actually, it can be normal saline or ringer lactate. Okay, and lactate as such in pregnancy, lactate levels can be altered, but still lactate is one thing that we should be meticulously following, because lactate above 4 means it's a bad prognostic sign, and our resuscitation has to be spot on. Okay.
Ma'am, I think it's been a wonderful last 115 minutes or so, ma'am. We've been 115 minutes here, just 5 minutes short of 2 hours here. So I think if there are any questions from the faculty side also, we'll just take it across and then we will just wind it up. Ma'am, anybody? Sajda, ma'am?
No, actually, it was an excellent, was a very nice, lively discussion. And I think about the fluid management I thought it's really very important. The fluid status keeps on changing, and like the Euroflow meter, as Madam said. So we need to manage that, like sort of hour by hour, change our decisions, and that's why this multidisciplinary care, the ICU care, is so important.
Hello, madam.
Hello.
Yes, ma'am. Yes, ma'am.
I'm Beena. I just wanted to add one point is that we usually give thromboprophylaxis in sepsis patients.
Okay.
So that will prevent further
Of course.
complications like thing.
Of
And
course.
one thing is if we go back to your COVID times, like 5 moments of hand hygiene before touching and after touching the patient, before procedure, after procedure, and before touching the patient surroundings. So strict hand hygiene can reduce the incidence of sepsis, and as Madam said, the proper news chart. And again, one more comment upon the Subhash's comment upon the young generation. Palpate the pulse once you see a patient. Palpate the pulse, palpate the abdomen, palpate the uterus, and palpate the wound. And we should be really careful in a post-operative patient having fever and abdominal distension. So that in all patients with abdominal distension and fever, do an early CCT so that any source of infection. So early imaging will go a long way. And straight away start her on higher antibiotics, hit it hard. So first antibiotic should be what here we follow is the cefprozone sulbactam and metrogel combination, and the dose of cefprozone sulbactam again instead of 1.5 gram it should be 3 gram IV BD. So that's all I want to
Yes, ma'am.
add.
Again, for the younger crowd,
As,
as you rightly said, for the younger crowd, ma'am, I believe that whenever you have an unexplained tachycardia, I think that should actually be quite alarming for you. Unexplained tachycardia, I think, would be the first thing to pick it up.
Yes,
As Madam rightly said, many a times we do not even see the
Yes.
pulse nor the
Yes,
abdomen.
yes.
That's something which is very wrong on our part also.
Subhash,
Ma'am.
I told you several times to comprehensively examine the patient, take a proper history, do a proper clinical examination. And I remember Matthew Roy sir teaching, you need not see the entire elephant to say that it's an elephant. You need see only the tip of the elephant's leg. See, I told you about the appendicular abscess patient. She was, there is a patient referred as pain abdomen, some intestinal problem. I just looked at the patient and immediately I said, without even touching the patient, she should be having sepsis because the ALNAC was working and she was having pain abdomen. She was having vomiting. I said, there is pus inside the abdomen. So that is the way you should look at the
Yes,
patient.
ma'am.
And
Yes, ma'am.
always deal with a pregnant patient as an immunocompromised patient.
Ma'am,
Always,
another
always.
thing is that which we find, take it light is urinary tract infection in pregnancy. If the patient is having tachycardia, UTI and fever, always think about pyelonephritis, where this patient can go in for endotoxic shock.
Shock and death. I have seen one patient die because of
Yes.
pyelonephritis.
Urosepsis can go in for.
And
Yes.
I usually teach my students there is urinary infection and temperature. You see, look for renal angle tenderness. If it is pyelonephritis,
Exactly,
you
ma'am.
can IV antibiotics.
Yes.
Otherwise, you can die of pyelonephritis, septic shock. Gram negative.
I think, ma'am, I think it's been very exhaustive and very, very nice.
Oh, very
I think before I close it down, ma'am, I would really
I
request.
exhausted even from the beginning because I couldn't enter. So I got exhausted.
You know, we had a lot of people who were saying, "Madam's mic is switched off. Madam's mic is switched off." So again, I think I'll give the last word to my president, Dr. Suchitra, madam, to just give her points of view, ma'am. Please, ma'am.
Good evening to all. I think it has been a wonderful evening discussing so many aspects of sepsis. And basically, I think Prasanna madam is an excellent teacher. She can express, she can really go to the root of the problem. And of course, with Dr. Arvind as a support, it was really wonderful. We really got a broad spectrum view of the entire sepsis problems. And actually, as Dr. Beena said, prevention is better than cure. Little bit of extra care, hand washing and keeping the patient clean and dry. All these things will prevent sepsis, and as far as possible, we should do the little things which can make the patient more safe. And thank you, madam, for that wonderful session, and thank you, Dr. Arvind, for all the inputs you have given us, and thank you all for joining in. We had a huge attendance today, and it is really wonderful. Thank you.
Thank you very much.
Once
Thank you very much,
Thank you, madam.
madam. Thank you, Arvind sir. Thank you, Shekaran sir.
And Shekaran sir also. Shekaran sir also.
Sajala madam, Jyoti madam, and the whole team. Prasanna madam, thank you very much. And Suchitra madam, thank you very much for the initiative along with Dr. Kunjumadin sir. Thank you, ma'am. Thanks.
Thank you.
Okay.
Arvind sir, a big heart out to you, sir. Thank you, sir. Thank you very much. Thank you, sir. Thank you very much.
Arvind, thank you for your very precious 2 hours.
Thank you, madam.
Arvind.
Thank you, sir. Thank you very much, sir.
Thank you, Kunjumaideen. Okay. Thank you, Sujitra.
Thank you. Good night, madam. So sweet. So nice of you.
Prasanna madam,
Wonderful.
madam സ്റ്റേജിൽ ഇരുന്നിട്ട് പോലും ഓഫ് ആക്കിയിട്ടില്ല, ഇവിടെ പേടിച്ചിട്ട്. രജീഷ് മാഡം പറഞ്ഞു, സുഭാഷ് ഇപ്പൊ ചോദിച്ചത്, മാഡം സ്റ്റേജിൽ ഇരുന്നിട്ട് ഓൺ ആക്കിട്ട് ഇരിക്കാം മാഡം, അവിടെ ഇരുന്നിട്ട്. പ്രസന്ന മാഡം സ്റ്റേജിൽ
ലാപ്രോസ്കോപ്പി സർജറിയും ചെയ്യുമായിരിക്കും.
ഞാൻ റിസ്ക് എടുക്കൂല മാഡം, മാഡത്തിന്
സ്കോപ്പും കൊണ്ട് നടക്കൂല്ലേ.
I saw you at the fag end, madam. ഞാൻ ഇപ്പം once I went to the delegate list, I saw you. അത് immediate മാഡത്തിന് മറ്റു ലിങ്ക് വെച്ച്, മാഡം പ്ലീസ് ജോയിൻ ചെയ്യാന്ന് പറഞ്ഞിട്ട്.
ഞാൻ ജ്യോതിനെ കാണാത്തപ്പോ ഞാൻ വിളിച്ചിരുന്നു, അല്ല വിളിക്കല്ല, മെസ്സേജ് അയച്ചു. അപ്പൊ ലിങ്ക് ഇല്ലെന്ന് പറഞ്ഞപ്പോ ഞാൻ ലിങ്ക് അന്നേരം അയച്ചു കൊടുത്തു, പക്ഷെ ഇതിന് ശരിയായിരുന്നു.
Thank you, ma'am. Thank you very much, madam. ഒരു 225 ഉണ്ടായിരുന്നു. At one point of time 225 ഉണ്ടായിരുന്നു, madam. 225. ടോട്ടൽ ലോഗിൻസ് ഞാൻ പിന്നെ തരാം. മതലബ് ചില ആൾക്കാർ ജോയിൻ ചെയ്യുന്നു, പുറത്തിറങ്ങുന്നു. ബട്ട് at one point of 225.
Thank you.
ഇവിടെ മാഡം എല്ലാവരും ഉണ്ട്. വീരേന്ദ്ര സാറ്, ഡോക്ടർ തസ്നീം, ഡോക്ടർ രജീഷ്, എല്ലാവരും ഉണ്ട് ഇവിടെ.
എല്ലാരും കൂടെ ഭക്ഷണം കഴിക്കുക.
ശേഖരൻ സാർ ഉണ്ട് മാഡം. ശേഖരൻ സാർ അടുത്ത റൂമിലാണ്. ഓൺലൈൻ രണ്ടും കൂടി ആയിട്ട്. Thank you, ma'am. Thank you very much, ma'am. Thanks.
Good night.